Mucormycosis is a severe, often rapidly progressive invasive fungal infection caused by molds of the order Mucorales, primarily affecting immunocompromised hosts and those with specific metabolic derangements. The most clinically relevant genera include Rhizopus, Mucor, Leucthemia, Cunninghamella, Apophosomyces, and Saxonia, with Rhizopus oryzis being the most common globally. Structurally, Mucorales species are characterized by broad, ribbon-like, non-septate hyphae that exhibit angioinvasive properties, leading to tissue infarction, necrosis, and hematogenous dissemination. In susceptible hosts, spores adhere to and invade respiratory epithelial cells via cot-H surface proteins and other host receptors such as GRP78, facilitating tissue invasion. Predisposing factors for mucormycosis are well established and include diabetes mellitus, particularly with ketoacidosis, is the leading risk factor worldwide, especially in Asia. Hematologic malignancies, allogeneic hematopoietic cell transplantation, and severe graft-versus-host disease are predominant risk factors in Europe and North America. Solid organ transplantation, prolonged high-dose glucocorticoid therapy, metabolic acidosis, iron overload states, severe malnutrition, and low birth weight are also recognized risk factors. The COVID-19 pandemic has led to a marked increase in cases, particularly in India, due to the convergence of poorly controlled diabetes, corticosteroid use, and COVID-19-induced immune dysregulation. Nosocomial sources, including contaminated air handling systems, hospital construction, and medical devices, have been implicated in outbreaks. Mucormycosis can manifest in several clinical forms, most commonly rhinocerebral, especially in diabetics, pulmonary, in hematologic malignancy and transplant patients, cutaneous, following trauma, gastrointestinal, and disseminated disease. The disease is notable for its rapid progression and high mortality, particularly when diagnosis and treatment are delayed. The diagnosis of mucormycosis relies on a combination of clinical suspicion, radiologic assessment, and laboratory methods, with recent advances improving sensitivity and specificity. The following diagnostic modalities are currently available and supported by the medical literature. Direct microscopy, mucorales are distinguished by broad, ribbon-like, non-septate or pauciseptate hyphae with irregular branching. Histopathology, definitive diagnosis requires demonstration of tissue invasion by characteristic hyphae in biopsied specimens, stained with periodic acid, Schiff, PAS, Grocott, gommery methenamine silver, GMS, or hematoxyliniacin, He. The presence of broad, irregular, non-septate hyphae invading tissue is diagnostic. Immunohistochemistry and fluorescence in situ hybridization, FISH, can further support identification. Culture, isolation of mucorales from clinical specimens, tissue, BAL, sputum, on Saborod's glucose agar or similar media is important for species identification and antifungal susceptibility testing. Mucorales typically grow rapidly, forming floccose colonies. However, culture sensitivity is limited, and negative cultures do not exclude disease. Molecular diagnostics, PCR-based assays targeting mucorales DNA in tissue, BAL, serum, or plasma are increasingly used. Specific quantitative PCR, qPCR, assays have demonstrated high sensitivity and specificity, especially in BAL and serum samples, and are particularly useful in immunocompromised patients. Molecular detection is more sensitive than culture and can facilitate early diagnosis, especially when combined with clinical and radiologic findings. MALDI-TOF mass spectrometry, when an organism is recovered in culture, matrix-assisted laser desorption ionization, time-of-flight mass spectrometry, MALDI-TOF-MS, enables rapid species-level identification, provided the laboratory database includes relevant mucorale spectra. Metagenomic sequencing, plasma microbial cell-free DNA sequencing is an emerging tool that can increase diagnostic yield, particularly in cases where conventional methods are inconclusive. Its utility is still being defined, but it has shown promise in immunocompromised patients with suspected fungal pneumonia. Imaging, while not specific, radiologic findings, e.g., CT with intravenous contrast, are essential for identifying disease extent and guiding biopsy. Features such as the reversed halo sign, consolidation, and vascular abnormalities may support the diagnosis in the appropriate clinical context.
Management of mucormycosis. Management of mucormycosis requires a multimodal, aggressive approach. Initial stabilization and diagnosis. Initial stabilization includes assessment and correction of hemodynamic instability, metabolic derangements, especially diabetic ketoacidosis, and organ dysfunction. Early recognition and prompt initiation of therapy are critical, as delays in antifungal treatment are associated with increased mortality. Antifungal therapy. Liposomal amphotericin B is the first-line agent for initial therapy, typically dosed at 5 to 10 mg per kg per day, with higher doses for CNS involvement. Amphotericin B lipid complex is an alternative if liposomal formulation is unavailable. In cases of renal impairment, posaconazole or isovuconazole are recommended as alternatives or step-down therapy. Isovuconazole and posaconazole can also be used for maintenance therapy after initial response or in patients intolerant to amphotericin B. Combination antifungal therapy, amphotericin B plus anazole, may be considered in refractory or rapidly progressive cases, but robust evidence for routine use is lacking. Surgical debridement. Aggressive surgical resection of infected and necrotic tissue is a cornerstone of management and should be performed whenever feasible, in parallel with antifungal therapy. Early and repeated debridement is associated with improved outcomes, especially in rhinocerebral and cutaneous disease. The extent of surgery is guided by disease localization and progression. Control of underlying risk factors. Correction of predisposing conditions is essential. For diabetes mellitus, rapid restoration of euglycemia and correction of ketoacidosis are critical. In patients with immunosuppression, reduction or discontinuation of corticosteroids and other immunosuppressive agents should be pursued when possible. Neutropenia should be addressed with granulocyte colony-stimulating factor or transfusions if indicated. Iron chelation with defersirox is not recommended due to lack of efficacy and potential harm.
Follow-up care. Therapy should be continued until there is complete clinical and radiological resolution of disease and restoration of host immune function. Serial imaging, CT, MRI, or PET, is used to monitor response. Therapeutic drug monitoring is recommended for posaconazole and isovuconazole to ensure adequate serum concentrations. Long-term follow-up is necessary to detect relapse, especially in patients with persistent immunosuppression. Adjunctive therapies. Adjunctive immunomodulatory treatments, granulocyte transfusions, cytokines, may be considered in select cases with profound immunosuppression, but evidence is limited. Novel antifungals and host-directed therapies are under investigation.